What I'm going to do this morning is talk a little bit about prevention and screening and the advances we've made in the field. And we know right now that melanoma is in a very exciting era. For the last 5 years, we've seen advances in treatment that have prolonged the lives of individuals with more serious disease involving the lymph nodes and other organs of the body. But it's very clear that if we were to enhance our screening and early detection efforts, we'd probably save the most lives from this disease. So here's my title slide, and I have no conflicts of interest to disclose. Can everyone hear me okay in the back? Okay. When we talk about melanoma or skin cancer control, we're really talking about primary prevention, which is aimed at reducing harmful sun exposure in individuals, and secondary prevention, which are our early detection strategies aimed at enhancing the skin exam by both patients and by their practitioners to result in a medical visit where a thinner, more curable melanoma is detected. Right now in 2014, we'll see over 76,000 cases of invasive melanoma. Those are the skin melanomas that have a potential to metastasize, to spread to other parts of the body. And we'll see many, many more cases of melanoma in situ, which is actually a non-fatal melanoma that just involves the top layer of the skin, so it can't get into the blood vessels and lymph channels and move to other parts of the body. Melanoma right now is the 5th most common cancer in men and the 7th in women. But what we've seen very alarmingly over the last 30 years or so is over a doubling of the incidence, the number of new cases of melanoma in young women that were born after 1965. So this is kind of a birth cohort effect. And we look for environmental factors, host factors, and genetic factors that could account for this significant increase in melanoma incidence in young women. And in essence, the only thing we can really pinpoint this, or in terms of a relationship, is the tanning bed use. So this is just another graph, and let me just see if I have a pointer here. I don't know if you guys can see it. If we take a look at women between the ages of 20 and 39, we can see these different time periods, and these are the different age ranges of women between those two groups, and that melanoma incidence has gone up over this time period dramatically. So in 2010, there were 4 studies worldwide which really cemented the evidence linking tanning bed use to melanoma. And one of the studies out of Minnesota showed a 75% increase risk of getting melanoma in individuals who had ever used a tanning bed compared to those who had never used one. We're estimating right now that each indoor tanning bed use will increase someone's risk of melanoma by about 1.8%. And so if you imagine that we see tanning beds used frequently in young women between the ages of 15 and 25, most of them use it over 10 times a year. You can start getting a sense of how high the risk becomes once you start using these devices. My colleague Marty Weinstock is a dermatoepidemiologist at Brown University in the VA Providence in Rhode Island. He has likened the tanning bed issue to an experiment on millions over the last 30 years, which is now revealing impacts. Now, this is a little bit of the information that Sam presented regarding the under 18 tanning bed legislation that aimed at melanoma was really critical in spearheading in the state of California, the first in the nation to enact the minor restrictions for tanning bed, followed by Vermont in 2012. And now we have Oregon, Nevada, Utah, Texas, Louisiana, Illinois, Minnesota, Delaware, and Hawaii, with an additional 10 states where, again, AIM is really pushing the legislators and the public health campaigns, working with the melanoma control experts to enact this ban. Because we do see behaviorally that the tanning bed addiction, the addiction to wanting to use these devices, really starts in younger age individuals. The tanning industry promotes their campaigns to young individuals, particularly young women. This is a terrific slide from my colleague David Polsky at NYU, and they just published a paper this week in the American Journal of Preventive Medicine, which took a look at both leisure wear, from bathing suits to sportswear, in men and women over the last century, and the degree of coverage that used to occur compared to what we see now. And look at the pre-1900s, I think they had estimated that the percent of body exposed here was about 18% as we moved to the 1930s. to the 1970s, where the bikini is developed in the 1960s, and then now 2000, and I think we're probably even less than now, given what my girls want to wear on the beach or in the pool, but we're about 90% in women, and it's not that much better in men. So again, the 1900s, early 1900s, as we move to about the 1930s, and here we've got Sean Connery playing James Bond, which is not in 2000, I think this is a little bit before, but very elucidating. And this study, the article didn't just go through clothing patterns, but obviously the science on it is that they matched this with melanoma incidence in both men and women and really tied together the spikes we saw in incidence, which actually follow the sun exposure by 30 to 40 years related to the clothing changes. So I think that again just highlights how important primary prevention is, protection from harmful UV radiation. We think that about 70% of melanomas in fair-skinned individuals worldwide are related to sun exposure. So here's a real opportunity to prevent disease. I know I'm telling my patients about this study in clinic all of the time, but for the very first time now, we have a study from Australia which showed that regular sunscreen use can reduce melanoma incidence. And this is a neat study. It's called the NAMBOR Skin Cancer Prevention Trial. It was conducted in the early 1990s, so 1992 to 1996. And they asked individuals to use just an SPF 16 sunscreen. And you can imagine that the sunscreens from the early 1990s aren't nearly as good as the ones we have now. There were about 1,600 individuals. Half of them used sunscreen on the head and arms only, and the other half were either asked to use it on a discretionary basis, meaning optional, or they were non-users. So 10 years after the 4.5-year period where they had conducted the trial, they saw 50% fewer melanomas in the intervention group. And if we took a look at the invasive melanomas, again, those that can be deadly, there was a 73% reduction in those. What I would propose here is this study looked at individuals that are 25 to 75 years of age, and we know that a lot or most of the harmful radiation from the sun comes even earlier than age 25. So if we really start thinking about sunscreen protection, sun protection practices in general in younger age individuals, we could make a significant difference. What's also interesting in this trial is that individuals had a lower risk of melanoma on all sites of the body, even though they only were asked to use sunscreen on their head and arms. And so this suggests that probably because of the education and awareness, they were sun protecting elsewhere. Now, what do we mean when we say you need to broadly protect your skin from the sun? So broad spectrum sunscreen. And I wanted to put in 2 or 3 slides on sunscreen because I think this is very confusing. It's very confusing in the lay press and what's on the web. So broad spectrum protection should protect against the shorter wavelength UVB as well as the longer wavelength UVA. And in reality, the chemical sunscreens that we have, which are actually the organic sunscreens, so organic from organic chemistry, it seems counterintuitive. You'd think the physical sunscreens would be organic, but they're not. But our chemical sunscreens are actually better at broad wavelength filtration than the physical sunscreens. And in the US, we have an agent called avobenzone, which is our predominant UVA filter. And that's been the UV wavelength that's been harder to filter out compared to UVB, which is shorter. The problem with avobenzone, though, is that it breaks down in the sun after about 20 minutes, and so it has to be stabilized with other agents. So in the US, as of 2009, all sunscreens contain octocrylene that have avobenzone in them, so it doesn't break down. It's still not a great sun filter when we compare it to other UV filters that have been developed in Europe, Australia, Japan, and Israel, and so on over the last 20 or 10 years. And those have superior UV filters to what's in the US sunscreens. And we've waited for years for the FDA now to approve these superior UV filters in our sunscreens. One of the ingredients which I promote is Tinosorb. I think this is terrific. Tinosorb has a couple chemical names, bimetrizonol, bicostrazole, and this is really a long wave UVA, UVB filter that doesn't break down in the sun. It doesn't have any safety concerns from the Environmental Working Group, and hopefully, because of the Sunscreen Innovation Act, which was just passed by Congress this past July, the FDA will now decide to incorporate these superior UV filters into our sunscreens in the coming year. So we're excited about that. Sunscreen safety, I just want to mention a few issues. The Environmental Working Group is a consumer advocacy group, and what they do is take a look at any study in animal models, which we're looking at mice and rats and worms and fish and so on, and they're taking a look at any study where there was some potential injury or injurious result from using an agent. These are typically studies where there's ingestion or injection, intravenous infusion of a drug, which is used in thousands-fold greater quantities than a human would use or get from applying a sunscreen on the skin. So while they have worried about the estrogen activity of oxybenzone, the free radical formation from retinol palmitate, parabens in breast cancer, and then the nanoparticles in those physical sunscreens, the FDA has really refuted any of these concerns and believes that the currently marketed sunscreens in the US are safe to use and doesn't question the safety of any of the ingredients. And we know that the benefits from sun protection outweigh the risks. I'm going to move a little bit on to melanoma mortality, which is where we start talking about screening. So this year, there'll be about 10,000 deaths from melanoma in the US, almost 2/3 of which will be in men compared to women, and I'll talk a little bit about why we think this is happening. Encouragingly, we've seen some reductions in melanoma mortality in our younger age population. Whether this is due to the prevention campaigns that have been enacted from the 1980s, we're not really sure. But what's clear is that the early detection of melanoma is critical to reducing the deaths. And again, we'd have the greatest impact on reducing deaths from melanoma in the next decade, not from new drugs, which are phenomenal. I mean, it's a new world of melanoma treatment, but really from preventing the disease and detecting it early. It's been said that melanoma writes its message in the skin with its own ink, and for all of us to see. This is from Neville Davis in Queensland, Australia, which has the highest rates of melanoma in the world. So why is early detection of this largely visible skin cancer so difficult? There are a couple of points to understand when we talk about how we're going to reduce deaths from melanoma, and they require an understanding of the tumor biology. We see different subtypes of melanoma, which might have different growth characteristics and potential to spread. We have to look at the epidemiology. Who gets melanoma? Who's most likely to die from it? And the sociology. How are people behaving in a way that we can really target the high-risk individuals for cancer prevention and early detection? What we know from worldwide studies over the past decade is that when we have physicians or other practitioners diagnosing a melanoma when the patient is unaware of it, that it's thinner than when a patient brings it to their attention. And what I mean by this is it's called opportunistic screening, when the doctor or nurse practitioner PA is looking at your skin and they say, that looks funny to me, and the patient says, I didn't know that was there. That tends to be a flat tumor that's not bleeding, compared to when a patient comes to see me saying, yeah, I was rubbing my back with a towel and there was a lot of blood on it. That's usually going to be a much thicker melanoma that's going to be more difficult to cure. We also know that individuals of lower socioeconomic status, meaning lower education, are much less melanoma aware. So early detection is difficult in that group, and we see higher rates of death in people with lower education, lower SES. We also see the highest rates of melanoma mortality in middle-aged and older men. We have a strong rationale to involve our primary care colleagues as dermatologists in early detection of melanoma, because most Americans don't have a dermatologist. Nearly 2/3 of patients with a melanoma diagnosis will see or report seeing their primary care practitioner in the year prior to the diagnosis. Middle-aged and older men, again, who are our highest risk group in terms of dying from melanoma, make several visits to their doc in the year. And again, physician detection of melanoma is associated with thinner diagnosis. The problem, though, is that the proportion of Americans who report having their skin examined by their primary doc is actually very low. This is a study out of the National Health Interview Survey, over 32,000 individuals, and only 25% of those surveyed said that they had ever had a skin exam by their primary care provider. That's opposed to high rates of mammography in older women, prostate screening cancer in older men, and colorectal cancer screening in both men and women. Again, as I mentioned, we're seeing a big change in how melanoma does based on patient gender. And this kind of graphical depiction showing that men have a significantly higher chance of dying from melanoma has been reproduced worldwide. This is looking at data over 30 years or so. And this is white men over 65 who've shown about 157% increase in the death rates of melanoma compared to women. This has also been shown to some extent in men between between the ages of 40 and 65. So this middle-aged and older male group remains our most concerning in terms of dying from disease. This is a graph from the American Association of Cancer Research progress report from last year. I don't have this year's report out yet, but melanoma was one of only 3 cancers. Let me find it here. Only one on of 3 cancers, or actually, sorry, 4 cancers. No, men is the blue. So one of only 3 cancers in men where the death rates were rising. And this is looking at mortality rates from 1990 to 2009. So only one of 3 cancers we see death rates rising, again, not seen in women. We've got a strong rationale, thus, to target older men. Men over age of 60 or 50 account for a high percentage of our melanoma deaths. And the problem we have had traditionally with men is that they participate in healthcare screening and navigate the healthcare system less effectively than women, which really brings into the point of involving women and partners and spouses into the melanoma screening in their husbands and partners. We took a look at Stanford in the middle-aged and older male group. Many of you might have been involved in the survey study we conducted in the mid-2000s, where we tried to define factors that were related to thick melanoma at diagnosis versus thin melanoma. And those that we found related to thicker, more dangerous melanoma included the nodular subtype, which I'll talk about, lower education, again, which goes along with lower awareness of the disease, and then patient detection over physician detection, as I talked about. We crafted a melanoma campaign for middle-aged and older men. We had piloted out many graphical designs to our patients, and if you're in the audience, I appreciate you helping us with this. But what we wanted to do was target the disease. We wanted to focus on the novel findings in our study, which suggested that we need to have older men get into the doctor. We should involve their partner or spouse in advocating for a skin exam, and we should involve the patient, the partner, and the physician in simply looking at the back. About 1/3 of melanomas in men occur on the back, and if we were to lift up the shirt in male patients during routine exams, even if they're coming for a wart on their finger, or more importantly in the primary care realm where someone's having their heart and lungs listened to, lift up the shirt and look at the back, we'd probably go a long way to reducing deaths from melanoma in older men. The concept that melanoma could actually be more biologically different or more malignant in men compared to women was proposed by the melanoma pioneer, Dr. Wallace Clark, in 1969. And as I've mentioned, we've largely attributed this to differences in behaviors of patients, so that delayed diagnosis screening difference between men and women. Over the last 2 to 3 years, though, it's become apparent that there might actually be a different tumor biology in men versus women. And this came out of some large cancer registries in Europe, Munich and the Dutch cancer registry, as well as a study out of the EORTC data. And the EORTC data is the equivalent of ECOG and SWOG in the US. It's a cooperative group of multiple countries participating in clinical trials. And in that study, the patients, who were largely older men and women, with advanced melanoma, had the same access to treatment, surveillance by their clinicians, as well as surveillance tests have indicated. And these studies have all shown that women have about a consistent 30% survival advantage compared to men, and that's overall survival, melanoma-specific survival, and time to lymph node or distant metastasis. And again, these were matched in the last study for the treatment that they had in the stage of disease and so on. What we did at Stanford was to actually look at younger men and women between the ages of 15 and 39, because we think that this population is sort of less involved in screening for their health in general. This is the impervious ages. People aren't going to go to the doctor, women only for reproductive health issues largely. So we combined our efforts with the colleagues in epidemiology at the Cancer Prevention Institute of California. These are our research epidemiologists who collect all of the National Cancer Institute cancer registry data. And we've had many successful collaborations in them, one of which was related to the tanning bed use and tanning legislation here in 2011. In our study, we looked at patients between 1989 and 2009. So this gave us an opportunity for up to 20 years of follow-up of patients to look at death rates in this young population. We had to look at non-Hispanic whites, which is always a criticism. Non-Hispanic whites, which is generally, we think, just Caucasians, to put it simply, are about 95% of the melanoma cases we see. We see so few melanomas in darker skinned individuals that we can't use them, those subgroups in a lot of the epidemiologic studies. And we're trying to do this. We're trying to look at a growing burden we're seeing of melanomas in the Asian populations, Hispanics, and even African Americans. But in this study, we limited it to whites. What we found over our young age group were 26,000 plus invasive melanomas over the 20-year period and over 1,500 deaths from melanoma. Males, not surprisingly, accounted for about 40% of the melanoma cases, but 64% of the deaths. But what was surprising is that when we looked at young men versus young women, young men were 55% more likely to die from their melanoma than young women when we matched their characteristics by the tumor site, the histology, the thickness, the age at diagnosis, other cancers, and whether they had regional lymph node disease or distant disease. So we don't really know why we were seeing this potential sex difference in melanoma survival. There have been other theories proposed. Is this a protective factor in women or a stimulating factor that makes melanoma more aggressive in men? And there are several theories for the differences, including sex hormone differences. We don't think this is estrogen-based. That would be the most obvious. There's been some animal models and other studies which have shown no difference in estrogen receptor beta between men and women. We've also had data from that large ERTC trial which showed no difference in women's survival pre or post-menopausally. Androgens are interesting. There's a recent study out last year looking at men with a history of prostate cancer who showed a significant risk in that group of patients for melanoma. Now, again, those are older men who are also going to have a lot of sun exposure, but they didn't see similar increased risks of non-melanoma skin cancers, basal cells and squamous cells. We don't know if this is differences between vitamin D metabolism, how the immune system is regulated between men and women, epigenetic changes, or how males and females respond to UV radiation in terms of exposure patterns or genetic mutations. So we're actively looking at this issue. Dr. John Sun Wu is PI and I'm co-PI on a study now at Stanford where we're really trying to look at immune differences in men and women with melanoma before and after immunotherapy at baseline, as well as some of these androgen differences and to discern this. So if we ask you for a donation of blood and as a new patient, that may be why, but thank you. So I want to talk about nodular melanoma. This is a tricky melanoma. I was just in the city yesterday lecturing with Axel Hauschild, who runs the melanoma program essentially in large parts of Germany. And melanoma that's nodular tends to elevate, grow, ulcerate. It tends to bleed. It doesn't tend to have asymmetry, which is the A, border regularity, color change, and growth in terms of diameter. Those are those ABCD warning signs. It often has what I call a Band-Aid sign. Patient comes in, yeah, I've had this spot. I think it's where I got a tick bite, or I think it's an acne pimple, and we'll take off the Band-Aid. It might be pink. So this has been a very difficult tumor or tumor type of melanoma to detect when it's early and more curable. And in fact, if we take a look at data, melanoma that's nodular in its histologic subtype is only about 10% of all the melanomas we diagnose, but 50% of those that are much deeper. And in a more recent analysis, similar numbers of the subtype melanomas, and 37% of the fatal cases were due to the nodular subtype. So again, it's a tough tumor to diagnose early, and what we've tried to do to enhance the detection of the nodular melanoma is to talk about elevation, not E is evolving, not elevation, but E is evolving where a lesion is changing differently than the rest. And then I'm a real fan of the ugly duckling clinical warning sign. This was proposed in Europe, and I think it's easy for patients and practitioners to remember. The lesion just doesn't match the rest. It doesn't fit in. I've talked about focusing our screening efforts also including the spouse or partner, particularly for older men who get more nodular melanomas, and they tend to be on the back. But this also begs the question of whether physician screening makes a difference in reducing deaths from melanoma. So in 2009, the U.S. Preventive Services Task Force issued a statement saying that the evidence for primary care-based screening, skin screening for melanoma or other skin cancers is insufficient. And that's because we've never had a randomized, controlled prospective trial to prove that skin cancer screening reduces melanoma deaths, although it seems intuitive that it would. The funding has never happened for this. It's a very difficult study to control for. The USPSTF is not saying that targeted screening of high-risk individuals, though, is not worthwhile. So we're not talking about targeted screening of individuals with strong family history of melanoma or atypical moles, personal history of melanoma by dermatologists. That's clearly a value. So what the USPSTF is trying to do is enhance the time that the PCP spend with their patients, the primary care providers. They want to get the best value out of that time before they put in a mandate to do skin screening. Since the 2009 statement, though, there have been additional data to support physician skin screening for reduced melanoma mortality and thickness. And this is one study out of Australia. It was published in 2010, and it looked at newly diagnosed cases between 2000 and 2003. There were about 3,700. And what they found are that individuals who had had a clinician skin exam within 3 years of their melanoma diagnosis were nearly 40% likely to be diagnosed with a much thinner melanoma, 0.75 or less. And they extrapolated this to the mortality statistics and found that this population of patients had a likely 26% reduction in the mortality risk compared to the patients who didn't have the exam. At the Lawrence Livermore National Laboratory, which is local, there was a very interesting several decades long program of education, self-exam, and limited screening in the workforce. This was due to concerns of exposure risk in that population for various cancers. So in this study, over time, there was actually a reduction in the crude incidence of new cases, so a reduction in incidence in the screening program, which took place from 84 to 1996, as well as a reduction in the number of reported deaths from those expected. So this is a workforce time series, not a randomized controlled trial, but suggests that screening makes a difference. At Stanford, we combined our efforts with those investigators at Michigan and Boston University, and we looked at 566 newly diagnosed adults with melanoma, so both men and women over the age of 18. And as I said, physician detection is really going to be associated with thinner tumors, but only about 20% of our patients reported that their doctor or practitioner picked up their melanoma. But what we found, though, is even having a skin exam by their provider in the year before diagnosis resulted in a 2.5 times greater likelihood of a thin melanoma, and the effect was even greater in men over the age of 60 who had 4 times that greater likelihood. So even though the doc wasn't necessarily picking up a melanoma or it wasn't evident on exam, just having the full exam seems to have benefited the patient in terms of awareness and so on. The best data we have to date, though, come from a project in Germany called SCREEN, and this was statewide screening for the North Schleswig-Holstein, which is the northernmost state in the country, in 2003 to 2004. They screened individuals over the age of 20, which is actually relatively young for melanoma screening, encompassing about 19% of the state's population, and you can see here that nearly 3 times as many women as men took part in the screening, 27% to 10%. So they screened over 300,000 individuals in this program that was supported by the government. It was funded in the sense that the practitioners were incentivized 30 euros to perform an exam, and all of the docs were trained with an 8-hour screening program. There was a huge physician uptake of this program by both the primary care doctors and the dermatologists involved. And what they found was an increased incidence of melanoma during the screen program, which is not surprising. That's looking at disease prevalence where we're picking up those new cases. The incidence then returned to normal. But more importantly, 5 years after the screening program end, mortality, the death rates from melanoma, declined by nearly 50% in both men and women in the state of Schleswig-Holstein, which is up here. Let me see if I can highlight it, compared to all other states in Germany and then to Denmark. And so this is very startling data. Now, as a result, I just want to show you, this is kind of what they were looking at, a very complex statewide effort, which would be incredibly difficult to duplicate in the US. But these are the participants. They could have had their exam by the general practitioner, referred to the dermatologist, or gone directly to the dermatologist. The number of excisions performed, nearly 16,000, to pick up 3,000 skin cancers. So that's a number needed to detect cancer or excised cancer rate of about a little bit over 5.5. And so this number we should bring down, but this is still a very interesting endeavor. And so the authors concluded that this data represents strong evidence that the skin cancer screening in the state of Schleswig-Holstein reduced mortality, and it really begs the question of whether now the U.S. Preventive Services Task Force needs to revisit the same issue in the U.S. in terms of our guidelines. And in fact, the USPSTF in June of this year just called for a systematic review of the current data based on the German experience and other publications. In 2008, because of the 2003 to 2004 statewide program, Germany actually enacted a nationwide screening program, which is unbelievable. This is for individuals over the age of 35, again, higher risk individuals. They've trained 45,000 plus MDs in a skin cancer exam. This accounts for 77% of their doctors. And over 30 million screens have been conducted to date. And so what we're hoping to gain from this will be enormously valuable data, is looking at the death rates and thickness at diagnosis nationwide in Germany with historical numbers, as well as between Germany and its border countries. So we're really hoping this gives us important data. One of the problems, though, that the U.S. Preventive Services Task Force has had is that magnitude of harms. No one's really been looking at what are the harms of screening. And for skin cancer, we think about misdiagnosis, over-referrals to specialists, over-diagnosis, resultant harms from biopsies, and over-treatment. And so one of my colleagues, Dr. John Kirkwood, who has co-directed our Melanoma Prevention Working Group with me since 2002, actually got full endorsement of the University of Pittsburgh Medical Center senior administration and physician leaders to run a 3-year screening program through the UPMC system, which he started last January. And what they are doing is training over 500 of their primary care doctors in the skin cancer exam practices. They're using a 1.5-hour web-based skin cancer curriculum. This is a very interesting curriculum. We're actually trying to pilot it in our large VA healthcare system as well, where we can teach primary care doctors how to look at the skin and diagnose. Okay, time? Okay, almost done. 2 more slides. So in any case, we've got, I should be looking at my own watch. I'm used to a counter. Sam's my counter. So we're very excited about this study, and we'll see what's happening. Importantly, just to mention here, thickness-specific incidents we can look at with other counties in Western Pennsylvania, skin surgery, specialist referrals, and then we can also look at anxiety measures in these patients who are screened versus unscreened. I'm just going to conclude with 3 slides on chemoprevention, because it's a very exciting field. So when we talk about primary prevention, chemoprevention allows us to prevent the disease at the outset. We had a trial open at Stanford, and again, if you were part of that, I thank you for your participation. But we look at these clinical atypical moles in patients as potential precursors to melanoma. We really believe most of them do not turn into melanoma, the risk markers for getting the disease, but we do see a high prevalence of these nevi in patients with melanoma. We've looked at a number of agents at Stanford. We studied Sulindac, which is a non-steroidal anti-inflammatory agent. There's some very interesting antioxidants being looked at. This one's in broccoli stems. This is a Tylenol overdose medication that's used, and a lot of very interesting agents we're hoping can prevent the disease. And as I mentioned, I do co-direct a melanoma prevention working group with Dr. John Kirkwood, and we have SWOG and ECOG affiliates. It's a very multidisciplinary effort, and we're hoping that we can conduct the first phase 3 chemoprevention trial of melanoma in the US within our group. And what my hope ultimately is that we can take this incidence curve of melanoma and with chemoprevention bring it down to 0. So thank you.